We now move on to a key aspect of fertility care. The topic is evaluating the endometrial receptivity for embryo transfer. Let's welcome Dr. Anupama R to share insights on this topic where precision makes all the difference between hope and success. Dr. Anupama is a graduate and postgraduate of Government Medical College, Trivandrum. She's the managing director and chief consultant of Pran Hospital. Welcome, ma'am.
Thank you. Respected chairpersons, dear distinguished delegates, dear friends, a warm good morning to one and all. At the outset, my sincere gratitude to Jagarshan sir and the team for giving me this opportunity. And my hearty congratulations for the 25 years of dedicated service in healthcare by KJK team. And I'm proud to say that I was also part of this wonderful team couple of years back. Sorry. So we ART specialists often feel that we have prepared the best seed and best soil, but the seed is not sprouting. Why? So there comes the role of endometrial receptivity. Endometrial receptivity is that period of endometrial maturation during which the trophectoderm of the blastocyst can attach to the endometrial cells and subsequently proceed to invade the endometrial stroma and vasculature. Basically, the trophectoderm of the blastocyst invading the endometrial stroma is otherwise known as endometrial receptivity. So for that, there is a window of implantation that usually coincides between 19 to 24 days of the menstrual cycle in a normal menstrual cycle. The synchronization between the trophectoderm of the blastocyst as well the endometrium is very important in this particular aspect, and any mistiming is a major reason for the implantation failure. What is the biology behind the receptivity? So basically, as you all know that in the proliferative phase of the endometrium, estrogen is the predominant factor. And estrogen is preparing the endometrium. And once it comes to the secretory phase, the progesterone will be on the rise and progesterone will be helping the stromal changes. And of course, there are cellular changes happening at the cellular level, the pinapod formation and the addition molecules and all those things. And there is a role for the genes. Up and down regulation of the receptivity genes is also there. So in this picture, you can clearly see the difference between the proliferative phase as well the secretory phase of the endometrium. There will be massive desudalization of the stromal cells in the secretory phase of the endometrium. The factors helping in implantation includes apposition, adhesion, and invasion. Apposition is basically the hatched blastocysts attaching to the pinapods of the endometrium. These pinapods will be forming in the mid-luteal phase of the in the cycle. And that is basically regulated by various cytokines like the leukemia inhibiting factor, which is the most important one, then the progesterones and the beta-3 integrin. And coming to the adhesion, and that means the blastocyst attaching to the endometrium. And for that also various cytokines are needed. And of course, the adhesion molecules are needed, immune cells, and beta-3 integrin and L-selectin. So there are certain other factors other than this, all these molecular and other factors. There are other factors which can also affect the endometrial receptivity, like the age of the patient. That's very important. So declining quality and receptivity with advanced maternal age. Then hormonal factors like thyroid disorders, PCOS, luteal phase defects, hyperprolactinemia, and all those things can affect the endometrial receptivity. Then lifestyle factors of the patient, like nutrition, obesity, BMI, stress, lack of physical activities, and all those things can also affect the endometrial receptivity. Of course, the most important is the pathologies of the genital system, like polyps, presence of endometriosis, presence of chronic inflammations, then infections and uterine anomalies. What are the of course, these are not the traditional methods. We are all now also following this ultrasound criteria and all. So ultrasound assessment. So what you can do in the ultrasound assessment to assess the endometrial receptivity. So basically, the ultrasound measures the endometrial thickness, the pattern of the endometrium, volume of the endometrium if you have the 3D facility, then endometrial peristalsis, the elasticity if you have the elastocyte facility, elastoform, then and the endometrial blood flow. Optimal thickness we expect is around 7 to 14 millimeters with a good trilaminar pattern. So this is one particular study showing the endometrial scoring system, which was recently published in last year. So there also that shows the importance of all these factors in assessing the endometrial receptivity. But the problem is that there can be inter-observer variation, and so it has only moderate predictive value. Then next is an histological diagnosis. Histological diagnosis can be taken by the noise criteria, based on the noise criteria. And that criteria specifies the presence of glandular development, stromal changes, as well the mitotic figures are the changes supporting the good endometrial changes. So here also the limitation is it is an invasive procedure. Then there also the observer variability will be there between the pathologists, and of course the results will also be delayed. What are the molecular markers of receptivity? The molecular markers basically are the addition molecules like integrins, then L-selectin and the ligands, and E-catherine, then cytokines like leukemia inhibiting factor, then IL-1, 6 and 11, and heparin growth factors, HOXA10, HOXA11, pinapodes, and MUC1 glycoprotein. So there comes the role of endometrial receptivity assay, so which has come in the market a couple of years back. And that is based on the transcriptomic test, where that will analyze the expression of the 248 genes involved in the receptivity. And it is specific to that particular patient. And so that is a peculiarity of this particular test. And there is a personalized window of implantation can be identified. And once they give a report that remains stable or consistent for a period of 3 years. So how will you do it? So here you have to prepare the patient as well. You are preparing it for a treatment cycle, like either you can go for an HRT cycle, like an HRT cycle, or you can take up the patient with a natural cycle or a modified natural cycle and go ahead with the endometrial biopsy. And the biopsy is performed from day of progesterone plus 5 days in an HRT cycle and LH plus 7 days in a natural cycle. And using the Pipli or any other curate you can use. Sorry. Then the tissue is preserved in RNA stabilizing solution, and the RNA is extracted and analyzed by the NGS technique or by the microarray technique. Of course, it has clinical applications in personalized embryo transfer. This is upcoming area in embryo transfer area in the field. So customize the transfer timing. So we can identify the patient's window of implantation and go according to that. And of course useful in recurrent implantation failures, and especially those with multiple failed attempts and those with less good quality embryos and all those things, or less embryos in elderly patients. Then can also increase the success rate in those with advanced maternal age and poor ovarian reserve. So coming to the interpretation of the error results, and the result will be coming like this: either receptive, post-receptive, or pre-receptive. If it is receptive, you can go ahead like that in your treatment cycle. If it is pre-receptive, you may have to wait for 1 or 2 days. You may have to add. Then 85% will be the diagnostic accuracy according to the results. Then progesterone plus 5 or 5 days can be added to it. And displaced window of implantation can be identified in around 30% of the patients. So ESHRE good practice recommendation says that, so whenever you suspect an RIF, so you have to re-evaluate the patient and re-evaluate the lifestyle factors and reassess the endometrium. That's very important. Then assess the APA, APS and all those things. Then we can go ahead with the karyotyping of the patient. You can go ahead with a good 3D ultrasound. Of course, hysteroscopy is very useful. Then endometrial function testing can be done. Then chronic endometritis treatment can also be, testing or treatment can be done. Then assessment of the thyroid function. Then progesterone can also be assessed. But there is no role for vitamin D testing, microbiome testing, then NK cell testing, uterine NK cell testing, T lymphocyte, or HLA, or sperm DNA fragmentation, all those things. It doesn't have a role in endometrial receptivity as testing. What are the pros and cons of ERA testing? So ERA, of course, has certain advantages like personalized transfer timing, then can increase the qualitative results, helps in the implantation, personalized window of implantation and all those things. But it is an invasive procedure. It is very costly. May not be affordable to all, especially after an IRT cycle and all. Then requires additional treatment cycle for the patient and mixed evidence in unselected patients and may delay the treatment also. And ERA only identifies only a minority of patients with RIF. Another important problem is chronic endometritis. So chronic endometritis may be there in most of the cases of secondary infertility because of the postpartum endometritis and all. And tuberculosis is also rampant in our part of country. Then in chronic endometritis, the hysteroscopic pathognomonic features are the micropolyposis as well as the strawberry spots. Then the main feature by the pathology is endometrial stromal cells. So for that, the same group has come up with the ALICE test, that is the analysis of infectious chronic endometritis test. The same technique is following. It is also identified by the NGS technique. There also the issue is that they cannot identify the antibiotic resistance, and it cannot identify any pathogen other than the pathogen there. Then detecting the apt pathogen is also, of course, difficult with this method, and 100% accuracy is not there. So more research needed in this particular area. The third option is EMMA. EMMA is endometrial microbiome metagenomic analysis. So here that also linked to the poor reproductive outcomes and all. So here this particular test can suggest probiotic or antibiotic treatment to balance the endometrial flora. But this particular test also cannot identify the antibiotic resistance, and potential for other pathogens can be missed, and the need for further research in this area also. So they expect the optimal bacteria to be there as the lactobacillus, and the pathogenic bacteria they grade it as staphylococcus, streptococcus and all. Other endometrial receptivity tests are upcoming, like the ER mapping based on the PCR technique, identifying the 40 genes. It's less costly and fast results. Receptiva DX, that is basing on the immunohistochemistry, and BCL6 protein is the marker for that, and which is useful in inflammation as well in endometriosis. Then the Win factor, that is following the RNA sequencing. It's a newer test. More research needed in all these areas. So what all interventions, according to ESHRE and all, what all interventions you can do in IRIF? Of course, you have to reevaluate your estradiol regime and all. Then genetic counseling is very important. You can advise the patient to go for a PGT and all. And PGT-A is very useful to rule out the aneuploidy in the embryos, which can be one of the most important reasons for the implantation failure. Then antibiotics, if you are suspecting an endometritis. Then blastocyst stage transfer gives better results. Then optimize the lifestyle factors. But there's no role for endometrial scratching or GCSF infusion, intravenous immunoglobulin or intralipid infusions or PRP or HCG and all those things. So what can we expect in the future? So everywhere artificial intelligence is penetrating. So definitely it will come into endometrial receptivity also. So by artificial intelligence and all, you can predict the receptivity from multiple data sources, and which can eliminate the need for biopsy. And then multi-omics integration, that means it includes all the omics like proteomics, metabolomics and all those things. And that will also help to give a more precise phenotyping. And remote monitoring is another option that is more patient-friendly approach. Then endometrial modification, all these receptivity assays need more studies and more interventions needed and more modification needed for all these studies already available. So how we can integrate all these things in our clinical practice? So for us, what we can do at present is we have to select the patient. So need not do the endometrial receptivity assay, which is available in the market for all the patients who are come to you. But you have to select the patients where you expect this particular test will be useful. So depending upon their age or depending upon the limited embryos or those who with multiple failed attempts and all. Then pre-test counseling is very important because these are very costly tests and they have a lot of limitations also. Then test the decision making. You have to decide about the particular test, whether it is needed for the patient and all. That you have to take the decision properly. Then the result integration is very important and outcome assessment is also very important. So to conclude, the future of embryo transfer definitely will be precision timing, and the patient selection is very important. Already I have told you. Then evolving technologies, more and more technologies needed, more and more advancement needed in already the tests which are available, and we hope for the better tests in future. And ongoing research definitely is going on, and large RCTs needed to stabilize most of the research materials available. So we are expecting all our seeds will become sprout and germinate and all, and in future with newer tests and newer technologies and advancements. So thank you all for your patient hearing.
Thank you, Dr. Anupama.